How do you measure something as, well, profoundly personal as the quality of someone's end-of-life care? It almost feels like trying to quantify compassion, doesn't it? Today, we're taking a deep dive into a really interesting study that tackled exactly this and looked at using these huge administrative health databases to try and assess end-of-life care quality. So our mission here is to understand the potential these data sets hold, maybe some surprising things they found, and just as importantly, their very real limitations.
Yeah, that's right. The study was specifically looking at the feasibility, the validity, and the reliability of using these admin databases for quality indicators. They focus on a specific group, women who died of breast cancer in Nova Scotia and Ontario between 1998 and 2002. And it really brings up that big question, can big data, as we call it, truly capture the sort of deeply human side of care at such a critical time?
What is it about these administrative databases that makes them so, well, compelling for this kind of research?
Well, the powerful thing about them, and the study points this out, is that they are population-based. They're generally unbiased and incredibly efficient for measuring certain aspects of care quality. They're collected continuously, too, so you get consistent data over time. And crucially, they include everyone, even people maybe not served by one particular hospital or clinic.
Okay, so they've got this wide reach. What specific things, what aspects of end-of-life care could they actually track using these databases?
So the researchers started off with, I think it was 19 potential quality indicators they were considering. What they found was that 7 of those were fully measurable using just the administrative data in both provinces. Think about things like the time between the last chemotherapy treatment and death. That's measurable. Yeah. Or the actual place someone died. Was it in a hospital or at home or somewhere else? Even things like how often someone visited the emergency room near the end of their life.
Okay.
They could also track, the number of days spent in hospital near the end of life and some aspects of like continuity of care.
Right. And how do they make sure this data was, reliable? How can we trust these huge databases for information that feels so sensitive?
That's a fair question. They actually went to pretty great lengths to validate it. They took the administrative data and compared it directly with detailed patient chart reviews, like looking at the actual medical records from a random sample of patients. And what they found was a very high level of agreement for many measures.
Really high agreement.
Yeah, for a lot of those 7 indicators, the match between the admin data and the chart was over 80%. They used some statistical tests, Kappa statistics, which showed excellent agreement for several measures. It means the data matched up very reliably.
Okay, so these databases, they're clearly good at capturing a lot of the, let's say, objective, quantifiable information, the numbers, the dates, the locations. But when we think about quality of care, there's just so much more to it, isn't there? Where did the study find the limits? What about those, human qualitative elements?
Ah, yes, that's the crucial point, isn't it? While this administrative data is invaluable for those quantitative things and looking at population trends, it simply doesn't capture these essential qualitative aspects, things that are incredibly important to patients and their families. We're talking about, psychosocial support, spiritual well-being. Was empathy shown? Was the patient treated with dignity? How good was the communication between the care team and the family? These are absolutely critical parts of truly good, holistic end-of-life care. And, well, you just don't find them in billing codes or hospital discharge summaries. Actually, it's interesting. Things like adverse events, complications or problems which you might expect to be documented well.
Yeah.
They actually showed quite low agreement between the chart data and the administrative databases. It suggests that maybe some of those complex clinical details don't always get captured accurately in the admin data stream.
Right, that makes sense. So, okay, pulling it all together then, what's our big takeaway from this deep dive into admin databases and end-of-life care?
I think the study makes it really clear. These databases are a feasible tool. They're valid, they're reliable, but for measuring specific population-based indicators of end-of-life care quality, they offer a really efficient way to monitor broad trends, compare across different regions, that kind of thing. However, and this is the big but their critical limitation, is that they miss those essential qualitative aspects we talked about: psychosocial care, empathy, dignity.
Yeah.
So the conclusion really has to be that administrative data should complement other methods. It shouldn't replace them. You still need things like qualitative research, talking to patients and families, purposefully collected clinical data to get a truly comprehensive picture. It's not the whole story on its own.
Okay, so it's a powerful tool, but only part of the toolkit. It leaves us with a thought, doesn't it? As our healthcare systems rely more and more on data, become increasingly data-driven, how do we make sure that those invaluable sort of human elements of quality care don't get overlooked or even undervalued just because they're harder to measure with these big data sets? And maybe what are the best ways we can start to integrate all these different kinds of data, the quantitative and the qualitative, to build a genuinely complete picture of the patient experience, something for all of us to think about?